Good morning and welcome to day 2 of our 2022 Center for HIV Prevention and Health Services Integrated Statewide meeting. Again, my name is Aaron Davis and I am the Deputy Chief of Program Development in the Center, and we are happy to see everyone back to continue the discussion on improving health equity and our funded HIV prevention and care programs in keeping with our theme of improving health outcomes by focusing on health equity. Again, we invite all of our participants to engage with presenters using the chat feature during Q&A sessions, as well as with each other in the networking lounge on this and other topics. Again, a few quick reminders and housekeeping items. As with day 1, we invite you to be present for the final day of our statewide meeting because we don't want you to miss anything. Second, PowerPoint presentations, again, will be made available in the platform soon after the event concludes, so don't miss that. Third, if you experience any technical difficulties with the platform, please select the message support option at the bottom of your screen where you can email our customer support team who can assist you further. We also want to make mention of our evaluation. You can access the evaluation for the meeting by navigating to the evaluation menu in the top banner of the platform. We ask that all evaluations be completed by Friday, September 30th. Your feedback is important, valued, and considered when planning future meetings and helping us expand the vision of improving health outcomes by focusing on health equity. If you complete the evaluation by the deadline, we will show our appreciation by providing you with the option to receive a live Maryland branded incentives. So definitely a great thing to complete that evaluation. So we are ready to get started. For our first morning session, we will have Bobby Rogers, Deputy Chief of Program Improvement in the Center for HIV Prevention and Health Services, who will come and introduce our morning keynote speaker. Following our keynote, we will have a presentation from Shardai Jones, epidemiologist and evaluator in the Program Evaluation Unit of the Center for HIV Prevention and Health Services, on the outcomes of our assessment of Maryland Early Intervention Services. Thank you so much, and take it away, Bobby.
Good morning, everybody. I am Bobby Rogers, Deputy Chief of Program Improvement in the Center for HIV Prevention and Health Services. It is with great pleasure that I introduce this awesome professional and friend. Dr. Kamla Sanasi is a board-certified infectious disease physician with Prisma Health, the University of South Carolina School of Medicine in Columbia, South Carolina, where she serves as a program director in the Infectious Disease Fellowship Program. She received her medical degree from the University of Guyana in Georgetown, Guyana, South America, and completed her internal medicine residency at Howard University School of Medicine in Washington, D.C. Following her residency, she completed a fellowship in the infectious disease at the University of South Carolina School of Medicine in Columbia. Dr. Sanasi's interests include HIV prevention with a rural health focus, LGBTQIA+ healthcare disparities with a focus in transgender health and advocacy, women's health, and bone and joint infections. I proudly introduce to you Dr. Kamla Sanasi.
Hi, everyone. Good morning. Apologies for not being on camera this morning. So we're going to get started. I have nothing else to add to Bobby's introduction. That's who I am. I have no disclosures. I do want to disclose, no financial disclosures. I do want to disclose that I do have some personal biases in that I am a cisgender hetero female, meaning I can speak on some of these things through my patients, friends, and colleagues' experiences and what the data shows, but not through my personal experience. And I will discuss sexual health freely. So I talk freely about sex, and because of my infectious disease background, everything leads back to HIV and STIs. And I would like to acknowledge the following folks for their additions to the slide deck. Thank you. All right, so here are our objectives for today. So what we're going to do is for us to understand the evidence behind the adversities faced by our LGBTQ population, we have to look a deep dive into our data as well as a deep dive into our personal practices. So as we go through the presentations, make notes, and we will discuss at the end with regards how we can, as a group, come up with methods to improve the care we provide for folks. All right, culturally competent care. What is culturally competent care? It's essentially accepting people for who they are, and we are here to provide a service. Our goals and STI and substance use disorders and mental health disorders is marching towards ending the epidemic. So what these various organizations have done is endorse culturally competent care, not only to force our hand in providing appropriate care, but to remind us that we need to think of it and look at the various inequities in healthcare. Because if we blanket it and say, we will treat each patient the same regardless of background, then we're missing key populations and the issues faced by them. So the biggest question we have to ask ourselves, and you don't have to answer this for me today, is, are we there yet? Are we ready? Are we equipped and fully prepared to march into this venture? So this is something I would like everyone to self-reflect on this. And, everybody will say, yes, we're prepared, but what we're going to do is take a deep dive into the data, especially around the data around associated with healthcare discrimination. So this is a study from the VA in terms of how confident they feel that they provide unbiased, culturally competent care, and only half of them were super confident. So the other question that we have to ask ourselves is, do we need to belong to the LGBTQ population to provide appropriate care? And the short answer is no, because if we treat everyone with respect and we respect their wishes, then life goes on, right? I really like this slide because what it shows, back in 1986, we're essentially doing the same thing as we're doing 2011. And then when the 2015 transgender survey came out, there were similar data from like the patient's perspective. So back in the day, back in the 80s, 40% of physicians were uncomfortable with lesbian and gay clients. Fast forward to 2011, once providers become aware of a transgender status in a patient, the discrimination goes up. We don't, even with us in sexual health clinics, STDs, HIV clinics, and primary care, we don't talk about sex and protection. And Bobby knows me, I talk about sex and condoms all the time, even with PrEP, because our patients will tell us, oh, we don't need barrier protection because we're on PrEP. There's also this perceived bias that hetero people have. So hetero meaning straight people. So the straighter you feel, and I'm doing quotation marks, what this group showed, the straighter people feel, the more likely they're going to anticipate risky behavior. And this is around PrEP and PrEP provision. And I'm talking about PrEP at an HIV conference, HIV treatment conference, because we have to take care of all the partners. We're doing it together, hand in hand. So as the cis straight folks have their biases, they're less likely to prescribe and engage people in care. All right, so this welcoming environment, it starts off with the making no assumptions, talking about gender identity, gender expression, sexual orientation. And under sexual orientation, there's a difference between who people are sexually attracted to in terms of physical sex, and then who people are attracted to in terms of emotional situations. So if you're not familiar with the gender unicorn, we'll send you the links later for the gender unicorn, because it displays nicely, very simplified, sex assigned at birth. That's your physical body part. And one of the things that as providers we need to get comfortable with as we're addressing people's body parts, don't reference the traditional names. So don't say, are you having a discharge from your penis, or are you having breast pain? So kind of get away from the organ labeling, because everyone may have their own name that they refer to their organs as. Here's why: because for some people, calling their front organ, the bottom front organ, a penis, may be stigmatizing. So for us as providers, we just have to ask really open-ended questions. We have to sit down and understand the difference between gender identity, which is essentially how someone feels, and then gender expression, how they present to you. So traditionally, people feel very feminine. They'll present to you in a very feminine dress code, but they don't always have to add up. Meaning someone may feel as female or feel as male or a man, but present to you in the opposite, just because they would like to please you or society doesn't allow for that. So the bottom line for us is, as we practice, it's a judgment-free zone. Having inclusive language, sharing our pronouns. So even if you are a hetero person, share your pronouns, be comfortable with it, normalize it. And something we have to understand as providers is not only transgender folks require the use of a pronoun. A cisgender male may use gender free pronouns such as they, them, or he, they, combo pronouns, or Z, Z-I-E is a gender neutral pronouns that can be used. As we're preparing to welcome people, whether it's a medical bus or an office space, we need to train all of our staff. So the driver of the bus, the front desk check-in person, because everybody needs to greet our patients with respect. This is how we are going to engage our patients and keep them in care. So these are examples. These are my pronouns. You can wear pronoun buttons, add it to your signature line if it's not there already. Because remember, if we continue with the idea of not talking about these, then we will miss a good few things. All right, gender neutral restrooms. Make sure you have labels. And the reason we're looking for appropriate labels is 9% of people were denied access to restroom on our largest transgender survey. So looking at transgender, I've discussed the data that shows that as a group, we're not ready. Some of us are ready, right? But as a group, we have to get everybody there. These are the concerns out of a transgender group, where gender affirming and non-discriminatory care were their top priorities. Things like HIV and HIV prevention, they're way lower down. So what percent of transgender clients experience discrimination? And I don't think I can see your answer. So I'm going to tell you it's 31 to 33%, and that's nationally. In Maryland, the number based on the survey, and I sent you I'll send you the link for the Maryland survey. It was only 10%. So it means in Maryland, we're doing a great job for the 100 people that answered the survey. This discrimination is higher among certain populations. So when it comes to like Native Indian transgender folks, that goes up to about 50%. Gay and bisexual men are less likely to talk with their primary carers about their sexual health. Even in my practice, I have people who have a primary care, but they see the infectious diseases docs for their HIV prevention, and it shouldn't be that way. We all need to have those open conversations. Some of this is fear of discrimination, low levels of insurance, or just having a negative experience. And one negative experience in one office could ruin it for all the other offices. As we look into, the social determinants of health and cost of healthcare and the stigma associated with healthcare, pulling out transgender folks and looking at the economic instability, whether it's because they have higher rates of unemployment, and that would have come from higher rates of getting kicked out of school or just dropping out because of bullying. It becomes a vicious cycle. So as we provide care, I'm not saying handouts, but as we provide care, we have to ensure we have interdisciplinary services that can assist with all of this. So it's not just our prescriptions, it's our housing, it's our getting people back into schools. So gender dysphoria is that distressed experience, but not everyone, but some people who identify as a gender that does not correspond to their sex at birth. So as we add to their distress, whether we insist on not using the appropriate name, or as in their preferred name, or not using their pronouns, the pronouns the patient wishes us to use, we add to this dysphoria. And this means lack of patients accessing healthcare. So LGBTQ people, do they have the same risk as the general population for suicide thoughts and suicide attempts? And the answer to this is false. So looking at our national rates and the map, I like this map because it gives us an increase over the last 10 years. And there is a 2020 map that we're going to send out the link on the resources that looks at the current rates for 2020. Maryland is not doing too bad. So that's great. It's not the heaviest color on the group. So kids in schools have higher rates of mental health complaints. Adults who identify as LGBTQ are twice as likely as their straight counterparts and to have mental health complaints. The other thing that we need to talk about here is these suicide thoughts, suicide attempts, they're more frequent in the LGBTQ population. When we look at transgender folks, higher rates of substance use disorders to help cope with their discrimination, their homelessness, their lack of resources, or just their personal dysphoria as well. Higher rates of intimate partner violence and higher rates of STI. When we look at intimate partner violence nationally, and I'll send you the link for the current dates, and the data that's there is from 2015, men have rates of 1 in 10 having experienced intimate partner violence. And when we pull out people who identify as LGBTQ, those rates are higher. They're more likely to have serious distress. Okay, drugs and alcohol use higher, binge drinking higher, which means we need to ask the right questions as we're seeing patients. Keep going. And those rates are higher amongst Hispanics and other people of color. When we throw in HIV and suicide ideation, we add to more risky behavior, which means more transmission of STIs. And this is evidenced by syphilis and the rise of syphilis, not necessarily the rise of syphilis in the LGBTQ population alone, but in everyone, and the use of chemsex. So chemsex is where people get high to have sex to cope with their distresses as well, and higher rates of that. So that's something we need to address, urging us to focus on our substance use disorders initiatives. All right, so distinct healthcare needs, looking at anal cancers. Everybody in people who are bottoms, everybody talks about pap smears and mammograms, right? What we don't talk about is anal cancers in people who have receptive anal intercourse. Need to get that history, and it's not just giving the patients the swabs to do themselves. We have to have, until we can get anoscopes done in every person who has receptive anal intercourse, we have to have a rectal exam. At least we can look and see, at least annually, see if there are any lesions there, and ramping up our vaccine efforts. I'm gonna skip this. This is just we can do it in the discussion at the end. Just talking about understanding what body parts are present in our clients, because queer people can have body parts that we're not aware of and can still become pregnant, still need certain cancer screening. So we need to talk about this. These are just some resources of where we can get information taking care of clients, including how we can get our office up and ready. The slide just, hammers home, like, this needs to be teamwork. So it's not just a one type of provider, it's everyone as a group assisting and helping. Okay, so CDC used to have the list of questions to ask. I like the ones that the questions that case managers use in their questions, because they're very open-ended. Who are your partners? What body parts does your partners have? What body parts do you use for sex? Very open-ended questions. What protection from STIs? And people will say PrEP, or HIV patients don't use condoms because I have HIV already. So the very high rates of STD, and understanding what body parts and if we need to offer people other methods of contraception for pregnancy. So in terms of LGBTQ rates, we'll skip the question, but in terms of within the LGBTQ population, we know already we have high rates of HIV. So because we know that these high rates, are upper level rates of HIV, are in people of color, right? Or MSM of color, both Hispanic and Black. So in terms of our focus, where we need to focus our initiatives, and I know you all know this, what I need to chat about is the next slide, is within the transgender population, our rates are extremely high. Adults identifying as transgender, from the time of them identifying or coming out per se to becoming HIV positive for the ones who did become positive, it's 5 years. So we have a small bridge of time to get people into care and treat them with respect, open questions, get them on PrEP if needed, get them their monkeypox vaccines, for instance. All right. So what the transgender survey showed us is that extremely high rates of HIV within the trans population. When you look at people of color, the rates are extremely high. When you look at transgender women of color, the rates as high as 19%. There's a newer data that with analysis that rounds it out at 14%. But compared to our national HIV rates, this is extremely high. So a population that we really need to get into care. So, as we march towards ending the HIV epidemics and our goals, we really need to come up with methods that we can engage the LGBTQ population. So our young Black MSM, our gender non-conforming folks, our non-binary folks, our transgender population, especially our folks of color, and working with the communities to ramp up HIV prevention as well as HIV treatment care. All right, we'll open for questions.
Hello, everyone. My name is Shardai Jones. I am the HIV epidemiologist and evaluator for the Program Improvement Units within the Center for HIV Prevention and Health Services. So today I will be going over some results of the Maryland Early Intervention Services Delivery Assessment. Okay, and for the Prevention and Health Promotion Administration, we do have our mission and vision here. The mission of the PHPA is to protect, promote, and improve the health and well-being of all Marylanders and their families through prevention, public health leadership, and through community-based public health efforts in partnership with local health departments, providers, community-based organizations, and public and private sector agencies, giving special attention to at-risk and vulnerable populations. We're going to focus on that today as well. For our vision, the Prevention and Health Promotion Administration envisions a future in which all Marylanders and their families enjoy optimal health and well-being. Okay. So the objectives for this presentation are, one, to review the program components of early intervention services. We are going to take a deeper look into the specific components of EIS to get a better understanding of what the questions in the assessment were aiming towards. And to review the EIS assessment of Maryland service providers. After taking a look into the specific components of EIS, we will then look at the outcome data of the EIS assessment and what we derive from those responses. Now, before we get into the outcome data of the assessment, let's first discuss what the program components of early intervention services actually consist of. So we have HIV testing and targeted counseling, referral services, linkage to care, and health education and literacy training. So EIS is provided at or in coordination with documented key points of entry. EIS services are coordinated with HIV prevention efforts and programs. Individuals who test positive are referred for and linked to healthcare and supportive services. Health education and literacy training is provided that enables clients to navigate the HIV system. Yeah. Now, the first step into early intervention services is to get tested. You need to know your status to be able to direct you into prevention or linkage to care services. There are many places that you can go to get tested. You can always go to your primary care provider or use a locator to find a place for you to help get tested. Next step are the referral services. If you are negative, we will refer you to prevention resources such as PrEP information. And if you are positive, this is where things become a little more detailed in which services you need, and we can refer you to get you into that case management and link to care as soon as possible. Now, excuse me. The goal for linking HIV clients to care is to get them into primary care within 30 days of being tested. So the HIV care continuum demonstrates the steps that people with HIV take from diagnosis to achieving and maintaining viral suppression. So taking a look at the HIV care continuum, here you can see the steps. So diagnosed with HIV, linked to care, received or receiving HIV medical care, retaining that HIV care. And by retaining that care, we mean that you had your follow-ups, had blood work done to determine your CD4 count or viral load test results within a specific time period. Now, some programs only require one visit within a year, while others may require more than one visit. And lastly, we have achieving and maintaining viral suppression. Now, this is the end goal, to achieve that viral load suppression and to actually achieve that goal. Now, we need people to be retained in their HIV care and keep getting those viral load test results to prove that your strategies and programs are working. And if not, what do we need to do to change and to get to our goal? Next, after our linkage to care component to EIS, we have health education and literacy. Now, this will provide education on the HIV service delivery system, how to work with your clinicians, how to handle certain problems and issues, and overall managing your disease progression and life with HIV. Now, this is where a lot of our case management comes in communication. Although case managers and clinicians are trained in the subject, every person is different. And if you communicate with them about your needs, wants, concerns, and questions, then we can guide you to the appropriate sources. Now, getting into the actual EIS assessment, the purpose was, so what was that purpose? You know, the Quality Management Division of the HIV Prevention and Health Services wanted to get an understanding of the models that agencies use for their delivery of EIS for HIV care and prevention. They did this by identifying the options around 4 client-centered building blocks. When are services provided? Where are services provided? Who delivered those services? And what services were actually delivered? There were 23 health departments and community-based organizations that participated in this EIS assessment. Here we have the main services that were or were not provided, and those are HIV testing, linkage to HIV medical care for those with an HIV reactive test, referral to support services to meet immediate needs to clients with a HIV reactive test, education on the HIV service delivery system and disease progression and managing life for clients with a HIV reactive test, referral to prevention and support services to meet immediate and ongoing needs for clients with a non-reactive HIV test, and education on the HIV service delivery system and disease progression and managing life for clients with a non-reactive HIV test. These services were our focus areas when we asked providers those 4 client-centered building blocks, the when, who, where, and what. I will go into specific questions asked under each service to get a better understanding of what information those building blocks were aiming to gather. There we go. The first service that we wanted to learn more about from our providers was HIV testing. As you can see, we are asking who gathers the testing services, and the options we have here are either clinical provider, college-educated non-clinical provider, or community health worker. Next, we have where is the HIV testing provided, and the options of clinical or non-clinical facility. And lastly, when is the HIV testing provided, with multiple options to choose from. So we have during regular office hours, after hours, including the weekends, requested by the clients, and other specific times requested either by the client or by the clinician. So these questions are a prime example of what we ask within the other services provided. Now let's take a look at how the health departments and CBOs answered those questions. Here we can see that when we asked who provided the HIV testing services, 13 health departments and CBOs said that they were provided by a clinical provider. 16 said a college-educated non-clinical provider, and 17 of them said they were provided by a community health worker. The next question of where HIV testing is provided showed results that majority of the health departments and CBOs had their HIV testing provided at a clinical facility. And now for clarification, participants could choose more than one response. So many said that they provided testing services at clinical and non-clinical facilities. Here for linkage to HIV medical care for those with a HIV reactive test, we can see that as for who provided the linkage to HIV care, the responses were kind of scattered. We have majority of participants say that a clinical provider was the one who provided the linkage to care. But again, our health departments and CBOs could choose more than one option. We had some say that all three of those categories were able to provide linkage to care for HIV positive patients. Now, when it came to where they gave the referral to get the HIV care, majority chose a clinical facility, but not too far behind. People also chose non-clinical facility. Not to make too many assumptions, but with our knowledge, we can maybe take a guess as to what those non-clinical facilities may be, such as, support groups and such. Now, this graph shows the who and where to referral support services to meet immediate needs to clients with an HIV positive test. Now, respondents mainly said that clinical providers were the ones who gave their referrals to the support services they needed. An equal amount of respondents said college-educated, non-clinical provider, and community health workers were the ones giving out the referral. When it came to where the referrals were made, majority of our jurisdictions and CBOs said they gave referrals to clinical facilities. And that makes sense, especially because these are referrals being made to clients who have HIV reactive tests. Okay. This next graph shows who provided the education on the HIV service delivery system, managing life and disease progression. The who was majority the clinical provider who provided the education, but a nice amount of jurisdictions and CBOs said that their community health workers and non-clinical providers provided education as well. And now as for the where, most of the HIV education was provided at a clinical facility. There were some who said non-clinical facility provided education as well. Excuse me. Now for this category, referral to prevention and support services, there were a scattering of responses. This makes sense because these prevention and support services are for clients who had a non-reactive HIV test. So looking at these charts, all options of clinical provider, non-clinical providers, and community health workers were chosen. And as the ones who, gave the referrals. And as for the where, it was equal in respondents of where the referrals were actually made to. So either clinical facility or non-clinical facility, you could go to either or. Here we have the education on HIV prevention service delivery system and disease progression and managing life for those clients with a non-reactive HIV test. These responses also very scattered because, again, this is for clients who tested negative for HIV. All types of providers were chosen to have given education on prevention for HIV negative clients. And the location is varied as well for those clients because you can get education at a clinical and a non-clinical facility. Now, we just went through each specific service and looked at their responses for who and where those services were provided. As those responses were very different from each other, the responses for when these services were provided are a bit more similar. So just about all the responses from the health departments and CBOs were that those services were provided either during the initial testing encounter or during regular office hours. We had about a handful of participants who responded providing these services after hours. For the last few minutes of my presentation here, I would like to go over the importance of data collection and the different types of data collection that are predominantly used. So why do we collect data? Why is data collection so important? Well, data helps us make informed decisions. And if the data is showing that a particular strategy is going in a downward trend, we need to make the appropriate changes to fix that. And a lot of decisions, a lot of decision making will come into play either from outside stakeholders or other partnerships, even internally. Data is used for tracking your progress on whether or not your strategies are working within the communities that you serve. Some of the most popular forms of data collection, we all know: surveys, checklists, interviews, and focus groups. And other types of data collection consist of observations, utilization of documents and records, and things like that. So. There are two main types of data used in research and evaluation. We have quantitative data, which is more data-driven and given in the form of numbers and percentages, like what I just showed you. And they are more concrete and objective. Qualitative data is based on opinions and experiences and are more subjective. Next, I want to discuss data and health equity. We want to focus on vulnerable populations to get a more granular analysis of possible gaps related to health inequities. So for example, some of the vulnerable populations that we focus on are youth, Black African Americans, and MSM. Now, after analyzing the data, we have to ask ourselves some very specific questions. So what are the deficiencies in HIV testing? Linkage to care, retention to care. What are the perceived challenges in engaging this population? Is it transportation? Is it marketing, testing locations, engagement? What more do we have to improve on to be able to increase these numbers to get a more data-driven for our vulnerable populations, excuse me. So analyzing data within our vulnerable populations will help us get these answers, and even meeting with our respective stakeholders and jurisdictions to see where there is any lack in programming or communication and to go from there for improvement. This chart here is showing some of our vulnerable populations and how many people of those populations were HIV tested, and the percentage is out of everyone tested. And the target column is what we are trying to reach. Those percentages are from our HIV surveillance team here at MDH. And the gap from the target percentage and the percentage of those in our EIS program. But this is a clear example of quantitative data and gathering data on our most vulnerable populations to maintain equity in our data. That was the first part of my presentation. Does anyone have any questions for me, concerns, comments? Now, our next section is an interactive breakout group, and I will go over some of the details of this breakout group and what are we going to be working with, okay? During this breakout group, you all be using some mock data based on our state priorities and their vulnerable populations. With this data, we want you to devise not only a strategy, but an outreach program. And let's take a look at some of what you will be working with. Here we go. This is our outreach program setting. So before we get into the data, let's take a look at where we are actually trying to get our outreach programs to work. We have here Jones County is located in a rural area of a state with two very distinct geographic regions. Most of the county is characterized by residential areas separated by farmlands and fields. One section, however, is a very vibrant beach and tourist destination during the warmer months. This may sound very familiar, when mostly young and out-of-towners come to visit. So public transportation and access to healthcare is scarce, including to and from tourist areas, and residents of the county are accustomed to having to travel for the resources that they need. When we look at the data in the next few slides, remember this setting. The first table of data we will look at is its linkage to care. This is the first step in HIV treatment. Here you can see that we have our vulnerable populations, how many are linked to care, and what the target percentage is. So what are some ideas you can think of that will help us get closer to that target of 95% of clients that are linked to care within their first 30 days of being tested? Could we improve the timeliness of those diagnosed to when they are linked to care? Could we increase the use of case management and patient navigation? Could we decrease their barriers somehow by providing transportation? All of these examples could be what we need to drive our performance rate up to get those and who are diagnosed with HIV immediately into care. Let's take a look at retention to care. Getting our clients linked to care is the first step. So now we have to have our clients continuing on with that care. So in Jones County, you can see that in either vulnerable population, getting our clients to stay in care is somewhat of a difficult task. So we have the Black African Americans, we have 23%, women, 57%, youth, 32%, Hispanics, 20%, transgender, 45%. Now, for here, we want to come up with some ideas of how can we keep our clients in care? Can we do follow-up calls? Can we provide transportation? Because remember, in Jones County, people don't have a lot of public transportation. Public transportation is scarce there. So having a way to get to their appointment could be their biggest barrier to continuing their care. Now we are going to look at viral load suppression. So we have our vulnerable populations of Black and African Americans, women, youth, Hispanic, and transgenders. Now, as our clients are linked to care and retained in that care, through tests, we can determine if they are virally suppressed. Now, our target percentage for all of the populations mentioned, as you can see, still the 95% target that we're trying to reach. Now, analyzing this data, we can see that we have some work to do to get to our goal here. Before we can determine if someone is virally suppressed, we have to determine if they were in care since their last viral load test. And the aim is to get a viral load test within the year. And to do that, they have to be in care. So referring back to that previous slide that showed the HIV care continuum, we either have to improve linking clients in care or keeping them in care. And what are the suggestions that we can do those specific things to get our viral load suppression at our 95% target rate? So what else do we know? Here's some things that, we do know about the services provided in Jones County. So PrEP usage has increased from 15% to 35% in the last year, in all vulnerable populations. And the goal is to have 95%. HIV testing is available at the local health departments Monday, Wednesdays, and Fridays during business hours only. HIV educational materials at Jones County Health Department are very general and not specific to vulnerable populations. And referrals to support services are typically limited to what are available in-house in the health department. Now, before anything else, you need to come up with your SMART objectives or your SMART goals. S is for specific. Is your goal or objective specific enough that it tells us what exactly it is that you are trying to achieve? M is for measurable. Can you measure the progress towards the goal you are trying to reach? A is for attainable. Is the goal realistic enough to achieve? R is relevant. How relevant is your goal to our outreach program? And T is time-based. What is the time limit for achieving this goal? Are you giving yourself a month, 2 months, or this is a 6-month project that you want to do and then go back and look at progress from the beginning? Now, once you get the idea of what you want to do, these SMART goals will help you stay on track. Okay, so the instructions for our facilitate discussion here, which will be afterwards. Now, using the data just given that we just went over for Jones County, and remember also that setting here, they are limited transportation, they have a touristy area. We want you to develop an EIS outreach and testing program and use the following prompts to guide your discussion. So who is the target populations to focus your activities on? What are the barriers to the outreach strategy? Where is there opportunity for external partnerships? What resources are needed to implement the strategy effectively? Provide 2 to 3 SMART objectives / goals of the program. And looking at the data, what quantitative and qualitative information is still unknown? And when you actually get into your groups, you can discuss these questions, have someone write them down and try to just come up with that outreach program or that strategy and see where we can improve our numbers. We just showed you before. And that was it for me. If anyone has any questions, please let me know about either the EIS assessment data or your the breakout room information that I just discussed here. But thank you so much for your time. And yeah, I think that is it. Let's see. Looks like I have a question here. How do we define youth? So we define youth as anyone in between the ages of 13 to 24, 13 years old to 24, yes. And we always try to get as much as we can from that particular population, because sometimes those are the ones that are hardest to reach. Those are the ones who probably are having the most difficult with transportation because, you know, they're young, especially geared towards 13-year-olds, they're busy, and a lot of younger populations, we have to build that trust. So coming in and getting tested or staying in HIV care with clinicians and talking to their clinicians and talking to their case managers, if they are in care, we have to develop that trust with that younger population. Some of those in the older population, excuse me, older than 24 years old, we aim to keep everyone in HIV care as much as possible and get that viral load suppression to that 95%. But our focus here was to get that vulnerable populations because, again, they are the ones that we need. Okay. In EIS, everyone works with, the patients, case managers, and providers thoroughly through the process, which, yes, I do understand. I'm sorry if I omitted that part, but during the presentation of the EIS data for the provider survey. But if there are any more questions, please let me know. you can always reach out to our Prevention and Health Promotion Administration with our contact email there. And again, my name is Shardai Jones. Thank you so much for your time.